Hello, I'm Mort Kern from the University of California, Irvine, professor of medicine and interventional cardiologist, working at the Long Beach VA as well. And I'm here with my colleague Ziad Ali from Columbia University, director of interventional cardiology research. And we're at the TCT 2019, and we have just come from our session on the Opsens Luncheon Symposium on simplifying complex PCI using second generation optical fiber wires. Now, we had a wonderful panel. We had Ziad Ali, we had Dr. Evan Schlafmitz, we had Jungmin An from Korea, and Dr. Barry Uretsky from Arkansas. Each of these individuals presented a wonderful topic, and I'm going to ask Ziad, would you give us the take-home message that you came away with on this program?
Sure, absolutely. So I started off, as you know, and I talked about how currently invasive physiological assessment is a science that's sort of ahead of the technology. I think we have a very good idea and understanding of the physiological concepts, the background, but we're limited by the wires, and we have been traditionally. We recently completed a study at our institution which showed that 58% of over 1,000 tracings ended up getting tossed by the core lab, saying either there's pressure drift or artifact, something that ended up making them getting them excluded from being able to be analyzed. That's a huge problem.
That's a big problem. So I know you recommended to us something. What can we do to fix that 50% bad tracing track record?
So at least half of it more can be handled by the wire. So poor wire characteristics, particularly drift, can be simplified and corrected using appropriate technology. And that's really where I think Opsens has a major advantage. We've discussed this in the past. But as you said, this is a second generation opto wire going on to the third generation, where they've taken a lot of time and energy to make this as close to a workhorse as possible.
Right.
And focused on the areas that really matter to making this concept of a science ahead of the technology. The drift study, which was presented by Evan Schlafmitz, actually showed a very low level of drift in the proximal LED, which I think is very impactful. Previous studies have also shown that the OptoWire has significantly less drift than some of the competitors, including some of the other optical fiber wires. So getting this to the level where we can get to be a workhorse type wire, I think is going to be a major impact for the future of invasive physiology.
Right. Well, I think Barry Uretsky showed us about his results for using it as a workhorse wire to finish the procedure with the FFR. But before we get there, the drift study also pointed out something we're not as aware of or not sensitive enough to, and that was aortic pressure drift.
Yeah.
What should we do about that?
So actually I found that incredibly interesting, and most of the studies have not really focused on that. It's certainly not something that I've been routinely checking after doing looking for drift. I've sort of always blamed it on the wire. So as you mentioned, Evan showed that a substantial portion of drift may be actually attributed to the aortic pressure and nothing to do with the physiology wire. It certainly has reminded my practice to make sure and do a better job for quality, which would only add on to this 58%. So anything we can get this to get the quality of the tracings to the point where we can make decisions with them is welcome.
Right. Now, Jungmin An presented his information about the resting non-hyperemic pressure ratios, and specifically we heard today more about the DPR that Opsens is providing. So tell me about the non-hyperemic pressure ratios and the DPR specifically.
So as you know, since the advent of IFR, there's been an explosion in the number of resting physiological indices. From my point of view, there's a couple of absolutely key take-home messages. They're the same, they're the same, they're the same. They have the same cut point, and they provide the same diagnostic utility, both for determining whether or not there is a presence of a potential reduction in flow, but also from the point of view of physiological assessment as a whole.
I would agree. So let me just quick short answer question. Do you think there's any value to a randomized comparison of any of the DPRs to any of the other?
Actually, it's interesting you mentioned that. So I tried to power this study, and I made a slide about it. Actually, the standard deviation of the two wires, in order to create a superiority test, the sample size is infinity.
So that's
So
a
I
big
think that
number.
answers
That's a
that
big
question.
number. Okay, so let's move to one more point that I think this program highlighted, and that was the post-PCI FFR. Now, Dr. Uretsky's group has been using the OptiWire as a primary wire, workhorse wire, all the way through, finishing with the FFR. And give me your thoughts on how often we should do that, or why we're not doing it more.
Well, I'm going to start with why we're not doing it more, and that is because the technology, right? So up until really the Opsens wire, which handles more like a workhorse wire than any other wires, but has an incredible feature in this connect, reconnect.
Yes.
So being able to disconnect this, maneuver it, and reconnect it with really out a significant change in pressure really gets you to the point at which it makes it easy to do a post-PCI physiological assessment. At least in my practice, I found it difficult. I often ended up damaging the wire. It was difficult to get through the struts. I'd be pushing, and now I'm wondering, am I causing more harm than good? And this is another place where using a wire that gives you the flexibility to use as a workhorse, makes it a little easier to do than we have in the past.
And then, of course, the resting ratio is available when you need that.
Absolutely. So what we do know is that the resting indices in the randomized trials to date have shown equivalence in an intermediate population at 1 year. They're going to present the 2-year data here. But we don't have a lot of data, Mort, for the post-PCI assessment using resting indices. As you know, Barry and I are doing a collaboration to be able to answer that question for DPR, RFR, IFR, etc. And also we expect to see the defined PCI a 1-year post data next year.
Super. Let me finish with one question, critically hard. You have a patient with typical and atypical symptoms. He's mid-60s, risk factors of coronary artery disease. Stress test shows only a small apical defect. He has coronary artery atherosclerosis on his angiogram of a very mild nature. You do PDPA 0.91, DPR 0.88, FFR 0.79. What should we do with him?
Well, as you told me before, you mentioned to me before, Mort, what do you do when you're coming up to an intersection and it's got an amber light? I slow down. So I'm going to take the conservative approach. And I think that using physiology should not only be to tell us when we should be putting in stent, I think more importantly should be telling us when we shouldn't be putting in stents.
I couldn't agree more. I think that comments that were provided to us at today's symposium were conveyed nicely here by Ziad Ali, and we look forward to seeing you at our future symposium on coronary physiology, and thank you to OpSens.